Since we have been discussing about the pancreatic surgery, and we have been discussing so far about the pancreatic carcinomas, and obviously we have discussed about some of the congenital anomalies related to the pancreas. But today we're going to discuss the most common presentation of the pancreas and most important topic in the general surgery course. So we will be talking about the acute pancreatitis today. So actually, the acute infection of the pancreas is particularly called as the pancreatitis. If we talk about the causes for the acute pancreatitis, we know that almost 75% of the cases are due to the biliary stones. Like we all know that if there's a stone in the gallbladder, there is a chance that it will slip to the common bile duct, and by that passage it ultimately is going to slip toward the pancreas, and it will cause the acute infection, which is particularly called as acute pancreatitis. So in almost 75% of the cases, the cause is a biliary calculus. So that's why it is called as the biliary pancreatitis or the gallstone related pancreatitis. In 25% of the cases, the cause is obviously the alcohol use, and the exact mechanism for the production of the pancreatitis in the patients who are using alcohol excessively is not, the exact mechanism is not known, but there is more, almost 25% of the cases are because of the alcohol use and the tobacco smoking. So actually, if we talk about the causes for the acute pancreatitis, the most common cause is a gallstone. And whenever you are investigating a case of a gallstone, and you're also looking up for the stone in the common bile duct, then obviously there are some procedures like the MRCP and sometimes the ERCP, which is endoscopic retrograde cholangiopancreatography. So actually, post ERCP patient also develop the episode of the acute pancreatitis. So this is very common. So we actually put them in the same entity like the gallstone related pancreatitis or post ERCP pancreatitis. So the other cause for the acute pancreatitis is any kind of surgery, but specific surgeries which is related to the abdomen and the abdominal visceral, or related to the gut. So after the surgery, there's a likelihood that the pancreas are going to inflame, and the patient will complain about the acute pancreatitis. Besides that, if there is the history of the abdominal trauma, then obviously sometimes because of that abdominal trauma, there is injury to the pancreas, and that injury is actually causing the lytic enzymes, which are the pancreatic enzymes, to be released. And these we all know that most of the time these pancreatic enzymes, they're lytic themselves, so they start digesting their own cells, start digesting their SNI, that is ultimately leading to the acute pancreatitis. Besides that, there's some periampullary tumors which are actually involving the ampulla of the Vater, and they're originated in the second part of the duodenum. We all know that the main pancreatic duct is actually opening into the second part of the duodenum. So the ampullary tumors are also one of the causes for the acute pancreatitis. Particularly if we talk about the drugs, acetaminophen, and there are some other drugs which are also related to cause the acute pancreatitis. Benzodiazepines and antipsychotics, they're also well known for causing the acute pancreatitis. And when they're given in combination, they are more prone to develop the episode of the acute pancreatitis. Besides that, those patients or those people who are taking alcohol excessively in their daily routine, they are also in a good proportion to develop acute pancreatitis. Other than that, hyperparathyroidism and hypercalcemia, these are also the one of the causes for the acute pancreatitis. Other than that, if we particularly talk about the pancreatic causes, then the pancreatic divisum is one of the cause. Then there is another entity, which is the autoimmune pancreatitis, in which, we all know that the pancreatic enzymes, actually like the trypsin and the chymotrypsin, specifically if we talk about the trypsin, it is kind of the activity autolytic enzymes. So what they do is, actually in case of the autoimmune pancreatitis, there's some antibodies which are developed against the pancreas, and it start digesting its own cells, and it leads to the development of the pancreatitis. So autoimmune pancreatitis is one of the cause. There's another entity which is the hereditary pancreatitis, and there's some kind of the viral infections which can also lead to the acute pancreatitis. Another cause for the development of the acute pancreatitis is obviously the malnutrition, and because of the immunodeficiency state, and the immune system is not very much well developed because of the malnutrition to combat against the diseases. So in all those patients, they also develop. In case of the diabetics, there is also some kind of proportion, and the research says that diabetics also develop acute pancreatitis. So, but most commonly, if we talk about the causes for the acute pancreatitis, always remember that 75% of the cases, they are usually because of the biliary calculi, and actually there's a stone in the gallbladder, and it ultimately slips into the CBD, and through that common bile duct, it ultimately causes the obstruction and causes a pancreatitis. It is also evident that in case of the large pancreatic duct, in case of the large common bile duct and a small stone, if a stone is small and the diameter of the pancreatic duct or the common bile duct is very much more as compared to the diameter of the stone, then there is more chances to be for the stone to be passed from the CBD or the gallbladder into the pancreas, and it's kind of the obstruction, and it will lead to the acute pancreatitis. So 75% of the cases, they are gallstone related, and they also develop secondarily to ERCP, because in ERCP you are disturbing, or you're working on the pancreatic tissue, and ultimately because of that there's a pancreatitis. And other cause is, in 25% of the cases, they're the cause of alcohol. There's some drugs which are also notorious for causing the acute pancreatitis, like the benzodiazepine, some kind of the antipsychotics. And in case of excessive use of the acetaminophen, they also cause the pancreatitis. Other than that, any history of the abdominal trauma or the abdominal surgery, they can also cause acute pancreatitis. So most commonly, you should remember the biliary or the gallstone related pancreatitis, post ERCP, and alcohol. These are the most common causes for the development of the acute pancreatitis. And sometimes patient can also present to you because of the scorpion bite. Exact mechanism is still not known for that, but there's some kind of the interleukins and cytokines produced as a result of a scorpion bite, and they actually target the pancreas and they cause acute pancreatitis. And some of the causes for the acute pancreatitis is idiopathic, like cause is obviously not known. The second most important thing to be discussed in case of the acute pancreatitis is obviously the clinical presentation of the patient. So the first and the most important sign the patient will come to you is obviously the pain. And we all know the pancreas are located in the epigastric region, in the central, epigastrium, or the central abdomen. So the patient will typically present to you with a pain in the epigastric region, and sometimes because we all know that the pancreas is a retroperitoneal organ, so the pain also radiates to the back, right? So the patient will give you a typical history that I've developed a pain in my epigastric region, and that is radiating to back. Secondly, the patient can present to you with nausea, but most commonly, all the infective, like if the patient is coming to you with a UTI or the cholecystitis or the appendicitis, there's the cardinal sign for all these things of vomiting. The patient can present to you with nausea, the patient can present to you with a rapid vomiting, and there can be retching. And other causes also, the presentation for the acute pancreatitis, there can be hiccups. Why hiccup? Because if there's a peripancreatic collection, then it's going to be subdiaphragmatic, and obviously it's going to irritate the diaphragm, and because of that, the patient can present to you with hiccups. There can be tachypnea, there can be tachycardia, because if there is involvement, first of all, like the patient can be in a sepsis, right? Because the severe acute pancreatitis, it's very well known to cause the sepsis. So if the patient is in sepsis, there can be tachypnea, and there can be tachycardia, and there can be hypotension if the patient is in a septic shock. Now, we actually, on the basis of the clinical presentation, we actually divide this, the pancreatitis into mild pancreatitis, moderately severe pancreatitis, and obviously the severe pancreatitis. So, what is actually the mild pancreatitis, in which the patient is complaining that I've got an epigastric pain, and obviously the patient will also give the history of gallstones already, if they are already known to him, and you'll think about the biliary pancreatitis or the gallstone related pancreatitis. So in case of the mild pancreatitis, there would be epigastric pain associated with nausea and the vomiting, but there won't be any organ failure, multi-organ failure, and there won't be any complications. In case of the moderately severe pancreatitis, there can be local complication. First of all, there would be pancreatitis, and there will be local complication, but there won't be any multi-organ failure. But if in case of the severe pancreatitis, if the patient is in septic shock, or there's a renal shutdown, or the patient is disoriented, or the GCS is defected, and the patient is an NCAF, so that can be a septic NCAF, right? So that will show you the multi-organ failure. So if the patient is there are local complications as well, and obviously there's a multi-organ failure as well, then that would be treated as a severe acute pancreatitis. Actually, we divide this into three stages, like the mild pancreatitis, there's a moderately severe pancreatitis, and a severe pancreatitis. So in case of the mild pancreatitis, there would be epigastric pain and vomiting, and there would be no local complications, no multi-organ failure. The second thing is moderately severe pancreatitis, and in case of that, there would be local complication along with the pancreatitis, but there would not be any organ, there can be local organ failure, but there won't be any multi-organ failure. So in case of the severe pancreatitis, the patient would be in sepsis, there can be a septic shock, there can be septic NCAF, there can be multi-organ failure along with the local complications. So that's how we divide, because the treatment options actually, and what kind of care the patient actually needs for the acute pancreatitis depend upon the severity. Is it's mild, it's moderate, or severe? Because severe acute pancreatitis has got 70% mortality if the patient has already developed a multi-organ failure. or the patient has developed a septic shock, then obviously the mortality would be very much high. So talking about the investigation for the acute pancreatitis, obviously, first of all, you're going to go for the baseline investigation, like you're going to order for the complete blood count. And obviously, if there is acute pancreatitis, then the TLC would be raised along with the differential count, like the neutrophilic count would be raised. ESR, which is erythrocyte sedimentation rate, that would be increased. C-reactive protein, obviously, that would be increased. So you're going to order for the blood CP, you're going to order for the ESR and CRP. The most important investigation for acute pancreatitis is a serum amylase level and a serum lipase level. Serum amylase is less sensitive, less specific for the pancreatitis, but usually it's it's not that it's very cheap, it's not that expensive. So in a smaller setting, serum amylase can be and there's like no invasive machines to standardize that amylase. So serum amylase and lipase, but lipase has got a more sensitivity and more specificity for the acute pancreatitis. And one thing which is very much important, that the serum amylase level should be threefold in its increase should be threefold in case of its quantity or the amount. The usual limit for the serum amylase level is ranging from 0 to 90, but if it's 100 or it's 120, it's not considered to be very much significant. But if the digit is increased up to 300, 400, thousands, and the lipase is increased in thousands and 3,000, then obviously that will indicate about acute pancreatitis. So these are, and obviously you're going to order for the LFTs as well, because most of the time this biliary pancreatitis that would be associated with the obstructive jaundice, and you're going to order for the total bilirubin level, obviously, and then you're going to order for the direct, indirect bilirubin levels to differentiate between an obstructive jaundice with the hemolytic jaundice, and you're going to order for the ALT and ALP as well. And if they can be deranged ALT and ALP, because if there's damage to the CBD and there's kind of the presentation of obstructive jaundice and there is a spillage of the stone into the CBD, the patient will obviously complain about the obstructive jaundice symptoms. So these investigations are very much important. Now, if we talk about those investigations which are really going to help us, is the first thing is ultrasonography, and obviously it's going to tell you if there are some kind of calculi which are present in the gallbladder. It's going to tell you about the CBD diameter, if it is dilated or not. You'll get an idea like if there's a stone in the CBD or not, and obviously it's gonna give you the information about the pancreatic fluid. It's gonna give you information about the thickness of the pancreas. If this is increased, that's obviously gonna say. But the gold standard for the acute pancreatitis is contrast enhanced CT scan, because if the patient has developed the acute pancreatitis with necrosis, like necrotizing pancreatitis, then obviously contrast enhanced CT scan is a gold standard investigation, and it's going to tell you about the necrotic segment as well. So on the basis of your history and on the basis of the clinical examination, but because if the patient is complaining about the epigastric pain which is radiating to the back and it is associated with the vomiting and nausea and retching, and then you're going to examine the patient and there's a tenderness in the epigastric region, obviously you'll think about the acute pancreatitis. So after if your diagnosis is correct or not, you're going to investigate, and how you're going to investigate how severe is the attack. There's a criteria for that. Then obviously what is the thing is a Ranson criteria. So actually, this Ranson scoring criteria is like, first the criteria is calculated when the patient reported to you in ER, and after the 48 hours of the admission, there is also the revision of the criteria. So actually, this criteria, Ranson criteria, is very much important because it's going to help you determine the severity of the pancreatitis. As I have already described you, that there can be mild pancreatitis or moderately pancreatitis and or severe pancreatitis. So actually this Ranson scoring system and the criteria is actually going to help you determine the severity of the pancreatitis. So we have actually divided this criteria to be calculated at 2 points. One, when the patient is presenting to you and you're going to admit the patient, and after 48 hours of the admission, you revise the criteria and then you calculate it again. So for that, if you particularly talk about the admission, there are 5 parameters which you need to order. One is the age. Obviously, age of the patient is very much important. TLC count, blood glucose levels, LDH, and serum AST levels. So if the age is greater than 55 years and TLC count is like greater than 16,000, and blood glucose levels, they are greater than 1.1 millimole per liter, and LDH level is actually greater than 350 units per liter, and AST is greater than 250 units per liter. So on admission, there's the criteria for the acute pancreatitis. But after the 48 hours you're again going to calculate within the 48 hours, then hematocrit fall of 10% or greater than that, blood urea nitrogen if greater than 5 milligram per deciliter, arterial oxygen saturation is less than 8 kilopascals, serum calcium levels are less than 2.0 millimole per liter, base deficit is greater than 4 millimole per liter, and the fluid sequestration is greater than 6 liters. So if the criteria is this, then obviously the patient will fall in category of acute severe pancreatitis, right? So remember this Ranson criteria, which we use for the assessment of the severity of the acute pancreatitis. One is calculated at the time of the admission, and others calculated within the 48 hours, usually after the 48 hours. So the 5 important parameters which you're going to order and you're going to calculate for the acute pancreatitis is age if greater than 55, TLC count if greater than 16,000, and if the blood glucose level they're greater than 1.1 millimole per liter, LDH level of greater than 350 units per liter, AST levels are greater than 250 units per liter. So obviously you'll categorize this into severe pancreatitis. And if the hematocrit fall is 10% or greater than that, blood urea nitrogen is greater than 5, arterial oxygen saturation is less than 8 kilopascals, serum calcium levels are less than 2.0 millimole per liter, base deficit is greater than 4, and fluid sequestration if greater than 6 liters. Again, you're going to put it in a case of the severely acute pancreatitis or the severe acute pancreatitis. There's another scoring system which is called the Glasgow scoring system, and you calculate it within the 48 hours. If the age is greater than 55 and TLC count is greater than 15,000, blood glucose levels are greater than 10 millimole per liter, LDH levels greater than 600 units per liter, serum urea is greater than 16 millimole per liter, arterial oxygen saturation if less than 8 kilopascals, less than 60 millimeters of mercury, serum calcium levels are less than 2, serum albumin is less than 32. So actually there are 2 criteria. One is a Ranson criteria, I have already discussed in the previous slide, and there's another criteria slightly different from the Ranson criteria, and usually you calculate it within the 48 hours of the admission. So the parameters is age greater than 55, TLC count greater than 15, blood glucose level greater than 10, LDH level greater than 600, serum urea levels greater than 16 millimole per liter, arterial oxygen saturation if less than 8 kilopascals or less than 60 millimeters of mercury. Serum calcium levels, they are less than 2, and serum albumin is less than 32. Then obviously you're going to put it in severe acute pancreatitis. Now, after, when you're done with all the investigation, the basic investigation, the ultrasonography, and the other thing which is very much important is the imaging. So how you're going for this imaging studies. So the most important thing in case of the diagnosis of the acute pancreatitis is obviously the CT scan, and out of that, contrast enhanced CT scan is very much important, because if you're going to look up upon the pancreatic collection, or you're just you want to say if there's a necrotizing pancreatitis or not. And obviously, CT is the contrast enhanced CT scan is the investigation of the choice, or the gold standard investigation. Other than that, I have told you, like the ultrasonography, that is kind of initial investigation that's going to help you make the diagnosis. Like there would be peripancreatic fluid, and there would be increased thickness of the pancreas. So that's how you actually, from ultrasonography, you go to CT scan, and CT scan is the choice of the investigation which is going to help you. Now, when you're done with making up the with the diagnosis, the important thing in the management of the patient is initial management. Obviously, you decide the severity, you assess the severity of the pancreatitis, and obviously then upon the severity of the pancreatitis, your management depends upon that. The first thing is like you have to give a good surgical ITC, intensive care unit, care to the patient, and you have to admit the patient in a surgical ICU if there's this moderately severe or the severe pancreatitis. You have to put the patient and a good hydration. You have to, and just the first thing you need to do is you need to put the patient on oxygen therapy, resuscitate the patient, give good hydration therapy, or put the patient in good. Usually, some people think that there is no particular role of these antibiotics in case of the acute pancreatitis, but we try to give the antibiotics for the prophylaxis, and the choice of the antibiotics you have to give this as a broad spectrum antibiotic, like the 4th generation cephalosporin, or you put the patient on fluoroquinolone. So that's also good. And you also combine it with the anaerobic and aerobic cover, like the Flagyl, because the gut flora sometimes is causing that infection, which is acute necrosis of the pancreas, right? And sometimes there can be later in the stages, after the 4 weeks, there will be walling off of the that necrotic area. So that's good if you put the patient on antibiotic therapy. But the most important thing is like you have to NPO the patient. You have to label a VSIL, very sick, ill patient, on the bed of the patient. You have to give a good hydration, and you have to give the good oxygen supportive therapy. So admission to HDU ICU, the first thing you are going to do is the second thing, you're going to give a good analgesia, like give the strongest of the analgesia to relieve the pain, because the pain of the acute pancreatitis is somehow very, very bad. So you have to get the good analgesia. Aggressive fluid, at least if a normal 60 kg individual, then 3 liters of the fluid per 24 hours, and Ringer lactate along with the 5% dextrose, they are good fluid for the resuscitation of the patient. You have to put the patient on a supplemental oxygen and keep it at 2 liters per hour. invasive monitoring of the vital signs is somehow very, very much important, because if a patient is developing sepsis, or the patient is or have already developed a septic shock, then this invasive monitoring of the vitals and monitoring of the input output is very, very much important. And frequent monitoring of the hematological and biochemical parameters. For what? Because if there is a multi-organ failure, acute renal shutdown, or the patient is developing in CAF, then obviously there's and respiratory acidosis. Obviously the ABGs, they're very much important, and biochemical parameters like RFTs and the serum electrolytes are very much important. So you have to keep a very close monitoring of all these things. So admit the patient in a surgical ICU or HDU unit, give a good analgesia, get aggressive fluid rehydration, supplemental oxygen, invasive monitoring of the vitals, invasive monitoring of the input and output, and you have to, be very much vigorous managing the acute pancreatitis, and obviously you have to, repeat the biochemical and hematological parameters daily. And also put the NG tube, nasogastric drainage, because if there's a peripancreatic fluid and if when it's causing the peritonitis later on, then you have to keep the stomach empty. And for that, this is antibiotics if cholangitis suspected. CT scan is very much essential for the organ failure, and ERCP within 72 hours for severe gallstone, pancreatitis, or signs of the cholangitis. Because if within 72 hours, usually the severe episode, like the acute episode of the pancreatitis, that usually get resolved. So in case of that, after the 72 hours, you can go for the endoscopic retro-cholangiopancreatography. And obviously, what you have to do is you have to put the tube drainage is somehow very, very much important, right? So URCP within 72 hours of the severe gallstone or pancreatitis or signs of cholangitis. Supportive therapy for the organ failure, if develops, this is somehow very much important. If nutritional support is required, then obviously NG feeding, or you have to put the patient on a enteral or parenteral nutrition. So these are the things. Conservative management, that's very much important in the first 72 hours if you're managing the acute pancreatitis. Surgery is usually if you give a good aggressive therapy, good fluid, antibiotic cover, good ICU support, good vitals monitoring, then you can avoid the multi-organ failure. And if the patient has already developed the local complications in the multi-organ failure, and the pancreas has already developed the necrosis, either it's acute necrotic pancreas, and after the 4 weeks that the patient is developing the Waldorf necrosis, then obviously the choice would be the surgical option. In that case would be necrosectomy. But before that, you have to give a good ICU care to the patient. In case of the acute pancreatitis, the complications which can be developed, you should very much well known about the kind of the complications which are actually developing in a patient, right? So in the case of the systemic complication, there would be cardiovascular, like the cardiogenic shock. There would be so much of the strain to the heart, and the patient can develop the cardiogenic shock. There can be arrhythmias. In case of the pulmonary system, there can be ARDS, acute respiratory distress syndrome. Hematological abnormalities includes if the patient is already in sepsis, and after that the patient can develop DIC, disseminated intravascular coagulation. GIT, there would be ileus, there would be peritonitis, neurological status, can be visual disturbances, the patient can be in septic encephalopathy, confusion, irritability, already told you about the encephalopathy, and other like the metabolic complications. There can be metabolic acidosis, there can be hypocalcemia, there can be hyperglycemia, there can be hyperlipidemia, and other like They can be subacute fat necrosis, and there can be arthralgias. So when you're managing the case of the acute pancreatitis, this is somehow very much important to know that the patient of the acute pancreatitis, it is a kind of the surgical emergency, and if you do not give a good hydration therapy and you do not give good ICU support to the patient, complications can be developed. And even if the patient was undiagnosed, and he was being neglected and untreated, left untreated, then the patient can present to you with all these complications. In case of the cardiovascular system, there can be shock, there can be arrhythmias, there can be ARDS, like the multi-organ failure, like the sepsis, septic encephalopathy. There can be septic shock, there can be DIC. In case of the GIT, there can be ileus, septic ileus, and the patient can also develop like necrotizing pancreatitis and peritonitis, neurological abnormalities like the confusion, irritability, disorientation, or the encephalopathy. Metabolic complications are also very much important, and like there can be hypocalcemia, hyperglycemia, hyperlipidemia, in case of the metabolic disturbances. But if we talk about the local complications, there can be hemorrhage, there can be subcutaneous fat necrosis, or there can be like abscess formation, and later on there can be pseudocyst formation, which is a kind of the local complication of the pancreatitis. So this is very, very much important to categorize, to assess the severity, because if already the multi-organ failure is developed, then obviously the mortality ranges 50% to 70%. So that's how this is somehow very much important. Now, if we talk about the systemic complications, other than that, there can be renal failure, and the patient can ultimately go into acute renal shutdown. And we know that how bad this acute renal shutdown is, and that is the cause of the death of the patient if the electrolyte imbalance is not corrected, or the patient is not put in a hemodialysis, and the acute renal failure is not being treated. Now, if we talk about the local complication, there can be acute fluid collection, either in the peri-pancreatic region, or there can be a fluid accumulation in the peritoneal cavity, and that can actually cause the peritonitis. There can be sterile pancreatic necrosis. There can be infected pancreatic necrosis. Sometimes, what do you mean by the sterile pancreatic necrosis? That means that there was acute pancreatitis, and as a result of that, a local complication developed, and there was actually necrosis of the pancreas. But that was, sterile, that was not infected. But some of the gut bacteria or the gut flora, ultimately, they occupy that necrotic area, because that is a potential area for the gut flora to get stagnant and to get development progress. So that can actually, the sterile pancreatic necrosis can be converted into infected pancreatic necrosis. There can be formation of the pancreatic abscess. There can be a pseudocyst formation. There can be pancreatic ascites. There can be pleural effusion. Now, this pancreatic ascites is actually, again, the fluid collection in the peritoneal cavity, and as a complication, there can be pleural effusion, there can be portal or the splenic vein thrombosis, and there can be a formation of the pseudoaneurysm. So that's why pancreatitis is somehow very much important to be discussed, because it has got local complication, it has got systemic complication. So if we talk about the local complications, there can be pseudocysts, there can be hemorrhage, there can be abscess formation, there can be sterile pancreatic necrosis or infected pancreatic necrosis, there can be pseudoaneurysms, there can be pleural effusions, there can be pancreatic ascites, or if we talk about the multi-organ failure, then there can be cardiovascular complications, shock, and arrhythmias, acute renal failure. So that's how the severity of the pancreatitis should be calculated for that. Now, if we particularly talk about one thing that we discussed in the previous slide, that was about how to manage the acute pancreatitis. But initially, obviously, you have to do all that. You have to give a good supportive therapy. You have to retain the patient in ICU or the high dependency, giving a good supportive management, give good hydration therapy, good supplemental oxygen, and good monitoring of the vitals, and good monitoring of the biochemical parameters. So, if the patient has already developed the local complication of the acute pancreatitis, and how we are going to manage it, there's acute pancreatic fluid collection, then that would be quite obviously visible on the CT scan. So this is the contrast and CT scan, and you can see here that actually this is the area of the pancreas, and you can see here that this is the peripancreatic fluid, and somehow there is necrotizing pancreatitis as well. So again, for the acute peripancreatic fluid collection, you have to give a good antibiotic therapy, and obviously you have to drain that fluid, which is somehow very much important. How you're going to drain within the 72 hours of the admission of the patient or develop episode of the acute pancreatitis. You have to go for the ERCP. You put a T-tube, or you put a stent for the drainage of that peripancreatic fluid collection, and also you put the nasogastric tube in the patient. So in case of the sterile and infected pancreatic necrosis, if it is already infected, then you can see here this is the pancreatic necrosis, which is being visible on a contrast enhanced CT scan. So if the patient has already developed the necrotizing pancreatitis, and if it is sterile, then it's not settling on its own, then obviously you have to go for the necrosectomy. But if it is sterile, and if it's not sterile, it's infected, then you have to give a very good antibiotic cover to the patient. So in case of the sterile and infected pancreatic necrosis, the surgical option we have available with us is obviously the necrosectomy. And in case of the necrosectomy, what you do is actually you just give a similar incision. Now, the most important thing, the incision, that depends upon where the necrotic segment is already present. If it's involving the head of the pancreas, then you have to open the abdomen through a midline incision. And if there's involvement of the body of the tail of the pancreas, then you have to go to the retroperitoneum, right? So you will go for the more oblique, or the lumbar incision from the side, just like the incision you give for the exposure of the kidney. So you can see here in the diagram that this is the kind of the CT scan. This is the liver, this is the pancreas, stomach, and obviously the peritoneal space. And this is the access to the retroperitoneal space. So you can give the incision. If you are trying to approach through the retroperitoneal space, then you have to give a lumbar incision. And if it's involving the head of the pancreas, then obviously the midline incision should be given. Gastrocolic and splenocolic ligaments, they're being mobilized, and debridement is done, and obviously which is called as a necrosectomy. As you can see in the diagram, that this is actually the pancreas, which is lying in the C-shaped curve of the duodenum, and you just approach it by mobilizing the gastrocolic and the gastrosplenic and splenocolic ligaments, and obviously you get access to that, and you do the debridement. This can be obviously through midline laparotomy, or this can be endoscopic guided, and you can just place the stent or the T-tube by the help of the ERCP. You can put a T-tube in that, and the peripancreatic fluid collection can be drained that way. So that's how you go. It's a kind of a similar incision, the costal margin, and you're approaching the patient from a left lateral position, and you're giving a subcostal incision. It's also called a lumbar incision, extended subcostal incision to the back, and that's how you try to get access to the head and to the body and the tail of the pancreas, and you mobilize the other structures, and you do the debridement of the necrotic tissue. And for the peripancreatic fluid collection, you actually place a T-tube out there if you are going through a midline or the subcostal incision. But if you are not actually going for the necrosectomy, then what you can do is you can, through the ERCP, you can put the stent through that, right? So that's how you do this. This is the necrotic tissue in the snare, and there's the endoscope. So you can remove this necrotic tissue through endoscope as well, and then you can put the stent in that for the fluid collection. So again, this is the same thing. This is the same for after the necrosectomy. There can be fluid collection as well. So what you're going to do for that fluid collection, either you can go for a closed continuous lavage, or you can go for a closed drainage. Like you're just placing a T-tube after the necrosectomy. You're placing a T-tube into that fluid collection, or you're actually doing the open packing. You're keeping the wound open, and you are just keeping the drains, and you are exploring and changing the dressing daily. Or the other thing is that you just have to close it, and then you do the re-laparotomy. So for the pancreatic fluid collection, either it's putting a T-tube for the drainage, or ERCP guided stenting, closed continuous lavage. They can be closed drainage, they can be open packing, and visualizing the wound again and again if you have the availability of the theater in your hospital environment very easily, or you can go for the closure and the re-laparotomy. So if we talk about the complication, obviously there can be pancreatic abscess formation. So for that, you have to put the patient on a good antibiotic therapy, and you have to go for the debridement. For the pancreatic ascites, obviously the treatment of the choice is like you always have to consult the medical specialist, or especially the gastroenterologist, and they do the pancreatic, they do the ascitic tap, and this can be obviously the most important thing is the drainage of that fluid. So either you drain through the peripancreatic, and if ascites have already developed, then obviously you have to go for the ascitic tap and draining the ascitic fluid through the skin. And if there's a pleural effusion, then obviously either you do the pleuritic tap, or you put the chest tube in such kind of a patient to drain that particular effusion. In case of the portal or the splenic vein thrombosis, you have to put the patient on anticoagulant, either conservatively, or you go for the endoscopic injection or the banding, or you go for the beta blockers, or you put the patient on antiplatelet or aspirin therapy, and you put the patient on a systemic anticoagulation. I'll say that's a kind of a antithrombotic therapy. So you put the patient on the antiplatelet, anticoagulants, do the endoscopic injection or banding, or put the patient on a beta blockers. So sometimes there can be a pseudocyst formation. As you can see, this is the peripancreatic area, and after that the patient has developed a pseudocyst. It's a kind of, it's not a true cyst. It's a kind of because after that necrotic tissue and vault of necrosis, a kind of a cyst is developed, and there is a fluid and a pus collection just close to the margin of that necrotic area. So that can be a pseudocyst formation, and for that the treatment is the excision if you are just opening that, or obviously you have to go for the drainage. You can see here in the other diagram as well. So the drainage is for the pseudocyst, the drainage, like you can go percutaneous, which is percutaneous T-tube placement, or you go for the endoscopic stenting, which is ERCP, or you go for the surgical drainage. So obviously the treatment of the choices, again, depending upon the either you go for the percutaneous T-tube placement, you go for the endoscopic, or you go for the surgical resection. There can be other complications of the pseudocyst, like if there's an infection into that pseudocyst, then there would be formation of the abscess, or there would be systemic sepsis. There can be a kind of a rupture of the pseudocyst, and this rupture can be into the gut or into the peritoneal cavity. And if it's if the rupture is in the gut, obviously the patient will present to you with a GI bleed. There can be internal fistula. Or if the rupture is in the peritoneal cavity, then this can cause a generalized peritonitis, or there can be enlargement. And why there can be enlargement? Because if there's enlargement, that will indicate the hemorrhage, and this enlargement would certainly will cause a pressure effect. And these pressure effects then ultimately can develop the obstructive jaundice because of the biliary compression, and the patient can also develop the bowel obstruction. And the other thing is, like, the patient obviously will complain about the pain. And sometimes this is a kind of a rare complication, but this is very lethal, and there can be erosion into the vessel. And obviously, because if there is erosion into the vessel, there would be hemorrhage in the cyst, and there would be hemoperitoneum, right? So this was about the complications for the pseudocyst formation, and this is important to drain. If you have already found out to have the pseudocyst, this is somehow very much important to drain. Either you go for the percutaneous drainage, you go for the ERCP guided stenting, or you go for the surgical drainage, because the complications of the pseudocyst, they are difficult to manage. Even if the patient has developed the sepsis, or there is a generalized peritonitis, or there's a rupture into the gut causing the internal fistula, or GI bleeding, or there's obstructive jaundice, or the bowel obstruction. So that was about today's lecture. We have discussed so far about acute pancreatitis, how you're going to manage a case of acute pancreatitis, how we're going to investigate, and what kind of the treatment options we have available with us, and how you are going to deal with the complications for if the patient has already developed the complications. So that's all for today. Thank you for watching sqadia.com. Keep watching sqadia.com.